progressive abdominal distension and lethargy. His family reports that he has not been awake or fully alert for 4 hours. Okay. The patient has hyperlipidemia, hypertension, BPH, medication, atorvastatin, metoprolol, finasteride, daily aspirin. Temperature is fine, pulse is fine, respiration fine, BP low, pulse oximetry on 100% oxygen face mask shows oxygen saturation 99. The patient opened his eye and moved extremities to in response to painful stimuli. Abdominal exam shows distension over the lower quadrants, dullness to percussion to the level of the umbilicals, and an enlarged multinodular prostate. Mm. Bladder catheterization, yes, a lot of turbid urine. Piperacillin, tazobactam, large volume crystalloid, and norepinephrine are started. 2 hours later, the patient produces like 75 ml per hour of clear urine, but remains lethargic. BP is still low. Labs, hemoglobin, I believe that's normal. Hematocrit, leukocyte is high. Serum is low. Oh, sorry. Serum sodium is low. Potassium is normal. Chloride is low. Bicarb is normal. Urea is high. Mhm. Creatinine is high, and glucose is, I believe that's normal. Which of the following is the most appropriate next step in management of this patient hypotension? You know what? Hemoglobin is actually low. Yeah. And hematocrit is low too.
Okay. So IV administration of hydrocortisone is the most appropriate next step in the management. This patient presents with altered mental status, urinary retention, and evidence of UTI and sepsis with hypotension, evidence of UTI, sepsis with hypotension that is not responding to fluid correction, antibiotics, or first line vasopressor drug. Which okay, norepinephrine is given. First line vasopressor drug. Results of lab studies showing hyponatremia, hypochloremia, borderline hyperkalemia, and increased urinary nitrogen and creatinine, all the suggestive concomitant of adrenal insufficiency. Adrenal insufficiency, this patient with adrenal insufficiency may be related to hypoperfusion, may be related to hypoperfusion of the gland and unlimited to production of hormone, or it may be present the relative adrenal insufficiency and limited response to existing hormone that characterize the cause of sepsis. And there is this is disagreement around the pathophysiology and the clinical utility of routine adrenal insufficiency. However, this patient has refractory hypertension consistent with consistent electrolyte and acid base disturbance, and the presence of characterized presentation appropriately characterized as adrenal insufficiency regardless of underlying cause. In the setting, supplementation with IV administration of glucocorticoid such as hydrocortisone is the most appropriate next step. Limited responsive to vasopressor medication in sepsis. Limited responsive to vasopressor medication in sepsis is a hallmark of endocrine contributors to shock. Limited responsiveness to vasopressive medication in sepsis is a hallmark of endocrine contributor to shock. Okay, next.
22 male college student comes to the clinic because of a 3-month history of fatigue, persistent cough, chronic malaise, occasional night sweats, and a 15 weight loss 15-pound weight loss despite no change in appetite. He says he feels stress at school and his grades have been declining. He had infectious mono 5 years ago. He takes no medications and he where am I? He appears tired. He is 5'10", weighs BMI is fine. Pulse is fine, respiration are high, blood pressure is a bit low, cardiopulmonary exam discloses wheezing at both bases and distant heart sounds. Abdomen is soft with no tenderness. Liver edge is palpated 2 centimeters below the right costal margin. Don't know if that's, I don't know. Large matted lymph nodes are palpated bilaterally in the supraclavicular area, axillary and groin. Examination of a biopsy specimen of the superficial inguinal lymph node confirms the presence of wrist stem. Which of the following is the most appropriate next step in evaluation?
So lymphadenopathy, and they actually lymphadenopathy, fatigue, malaise, these are the features of Hodgkin disease, but they actually confirm that this is Hodgkin, like presence of red Steinberg cell. Okay, so the next step is to do the PET scan to, okay, Hodgkin disease is a type of lymphoma. Hodgkin disease is a type of lymphoma, predominantly B cell origin, that occurs most commonly in patients aged 20 to 30 and 55 to 60. Patient typically present with lymphadenopathy. Patient typically present with lymphadenopathy or a dominant lymph node mass along with non-specific symptoms such as fever, night sweat, weight loss, B symptom, malaise, hepatosplenomegaly, and pruritus occasionally presents. Uh, may be occasionally patients may be develop pale Epstein fever, which is characterized by pale Epstein fever, which is characterized by uh, Palestine fever, which is characterized by high fever for 1 to 2 weeks, followed by 1 to 2 weeks afebrile period. So high fever 1 to 3, followed by 1 to 2 week afebrile period. A specific sign for Hodgkin disease associated lymphadenopathy is associated with lymphadenopathy is a specific sign for Hodgkin disease. A Hodgkin disease associated lymphadenopathy is alcohol-induced pain at the enlarged lymph node. Alcohol-induced pain at the enlarged lymph node. The most common site for lymphadenopathy are the neck, and the most common site of lymphadenopathy are the neck and the mediastinum. Definitive diagnosis require core, needle, or excisional node biopsy showing red Steinberg cell, as in this patient. This is followed by either CT scan with contrast. This is followed by either CT scan with contrast or PET CT to identify the extent of the disease. Hodgkin disease is staged different differently than other lymphomas and typically have favorable prognosis. Lab markers are that are often increased in patients. Lab markers are often increased in this patient with Hodgkin disease, including markers of cell turnover such as LDH and inflammatory markers as ESR. Chemotherapy with concurrent radiation therapy depending on the location and bulkiness of the disease often curative. Okay.
67 man comes to the ED 20 minutes after sudden onset substernal chest pain. He has not had shortness of breath. He has hypertension and hyperlipidemia, medication enalaprine and statin. On arrival, he appears pale and anxious. His pulse is high, respiration normal, blood pressure low. Central
Read the
venous
last
pressure.
line. An ECG shows.
An ECG shows ST elevation in leads 2-3 AVF and leads VRV6, V4 RV6R. Which of the following is the most
What is your
appropriate?
diagnosis?
MI,
Which type of
STEMI,
and
like
2 2 3 ABF
lower the inferior.
inferior MI, like
inferior.
ST elevation in 2 3 AVF and ST depression in 1 AVL. Uh, and like inferior MI comes with other association, like it can come with uh, posterior or like posterior infarction. It there may be RB infarction, there may be posterior MI. So 2 3 AVF ST elevation looks like inferior MI, and inferior MI we need inferior MI only. This is the only MI which causes the hypotension bradycardia. So in inferior MI we need the fluid, and inferior MI beta blocker is avoided. Got it?
Mm-hmm.
Okay, I'm reading the explanation. You want
Okay.
me to read the explanation?
Yes, please.
Okay. Okay, this patient with substernal chest pain, increased troponin, substernal chest pain, increased troponin, and ST elevation in 2 3 AVF and in lead V4, V4R to V6R as a presentation of inferior MI with RV infraction. That's I'm talking about, like RV infraction for in. Okay. Acute coronary syndrome encompasses a spectrum of disease, including unstable angina, non-steady lipidemia, and steady lipidemia. Acute coronary syndrome classically presents with acute onset chest pain, often radiating to the neck, jaw, and or arm, along with the shortness of breath, nausea, and lightheadedness. Risk factors include a history of smoking, diabetes mellitus, hypertension, hyperlipidemia, obesity. Diagnosis is made based on the clinical history. Analysis of the cardiac biomarker will analysis of the cardiac biomarker will be increased in both ST elevated MI and non-ST elevated MI, but normal in unstable angina, and an ECG that may show ST elevation or depression or inverted T wave or Q wave in particular vascular distribution of the heart. This patient has inferior MI infarction evidenced by ST elevation in lead 2 3 AVF and right ventricular infarction as evidenced by ST elevation in V4R to V6R. Patient with right ventricular infarct often presents in cardiogenic shock resulting from acute dysfunction of the right ventricle. These patients are preload dependent. These patients are preload dependent, and elevation in V4 to V6 are patients with right ventricular infarct often presents with cardiogenic shock. Right ventricular infarct often with cardiogenic shock resulting in acute dysfunction of the right ventricle. These patients are preload dependent and should be given IV crystalloid like saline as a part of their stabilization. Treatment of patient with ST elevated MI requires administration of the antiplatelet drug, anticoagulant, pain medication, ultimately coronary revascularization. In case of ST elevated MI, the patient should go revascularization as soon as possible. Okay, look at the option C, IV administration of the propanolol
Mm-hmm.
would worsen the patient's hemodynamic stability. Propanolol is a non-selective beta blocker. Beta blocker is with similar activity of beta 1 and 2. It may be used in the treatment of hypertension, arrhythmia, migraine, essential tremor, hyperthyroidism. Administration of propanolol would decrease the patient's cardiac output and worsen his hypotension. So propanolol is not the choice, but beta blocker, like other beta blocker, is
Mm-hmm.
also not given in inferior MI.
Okay. Next, 22 women gravida 2 para 0 aborta 1 at 9 weeks gestation comes to the physician because of mild vaginal bleeding for 2 days. Her first pregnancy ended in spontaneous abortion at 6 weeks. She received the Rh immune globulin, and at that time, 3 years ago, she underwent multiple operative repairs of injuries sustained in a motor vehicle collision and received transfusion of packed red blood cells perioperatively. She has no history of serious illness. Her only medication is prenatal vitamin. Examination shows a uterus consistent in size with 9 weeks. There is scant blood coming from the closed cervical os. Transvaginal ultrasound shows a viable singleton baby is alive. Routine prenatal laboratory studies are performed and Rh immunoglobulin is given. Her blood group is B negative, Rh negative is sorry. Blood group is B, Rh negative. She is positive for the KEL antibody with a titer of 116. I don't know what that means. Which of the following is the strongest predisposing risk factor for is isoimmunization to the KEL erythrocyte antibody in this patient?
Okay, mother can develop antibody against RBC antigens after being exposed to fetal blood antigen during delivery or from previous transfusion. The likelihood of isoimmunization directly related to the amount the likelihood of the isoimmunization is directly related to the amount of the blood to which the patient is exposed. Thus, in this case, this patient likely develop antibody to the kill RBC antigen after being exposed to it in her blood transfusion. Additionally, blood transfusion are not typically screened for KL antigen. Blood transfusion are not typically screened for KL antigen in the US because maternal antibodies can cross the placenta. It is important to determine whether the patient's fetus has KL positive or KL negative RBC. If the fetus has KL positive RBC, the antibody created by the immune system would cause hemolysis of the fetal erythrocyte, leading to severe fetal hemolytic anemia and erythroblast fetalis, and likely fetal demise. As the mother has no signs of hemolysis in the presence of anti-KEL antibody, her RBC does not have KEL antigen. So, and she would not have contributed to a KEL antigen to her fetus. The easiest way to determine the antigen the status of the fetus to determine the antigen status of the father. If he is a KEL negative as well, then the fetus will be KEL negative and there is no risk of erythroblast fetalis. However, if he is positive, there is a possibility that the fetus will have a KEL antigen positive and suffer from erythroblastosis fetalis. Can you explain?
Oh, um, wait, what am I explaining? The why
The
what?
KEL one, yes. She is positive, like we have done the antibody testing to the mother and she is negative, isn't it? Like KEL antibody titer is 1 is to 116.
Okay, so she has the antibody. Seems like she is positive for the antibody, the KEL antibody. Mm-hmm. Okay. So, and they're saying that now we have to figure out if the kid has the antigen. Because if the kid has the antigen, then the antibody of the mom is going to attack the kid. But instead of going and taking like blood from the fetus or whatever, that's a lot of yeah, it can cause other issues. We can just check the dad, and if the dad is has the antigen, has the KEL antigen, then there is a probability that the kid can have the KEL antigen. But if the dad doesn't have the KEL antigen, we already know that the mom doesn't have the KEL antigen, then there is no possibility that the kid ever has the KEL antigen. So the fetus will be fine. I think
So
that's
we are
okay.
doing this KEL test for The history of previous spontaneous abortion, the 6 weeks gestation.
What do you mean? Like, what
Like
do you?
in the they said that blood transfusion are not typically screened for KL antigen in the US. So we are
Mm-hmm.
so normally they do not go for the KL antigen testing in the US. Not in
Mm-hmm.
normally.
Mm-hmm.
So why this patient got this testing antigen testing? You got
The
my point. Like this 22-year-old woman, why we have done the KL antibody or this testing? Is it a routine test?
No, no, no. It's just because she had an abortion before, a spontaneous abortion before. So now she's bleeding. So we're thinking, okay, she had an abortion before. She may have an abortion now. Maybe there is something wrong with her that is causing the abortion. So now we find out, we take the blood and we find out, okay, she doesn't have the RH, which is the common one, the RH thingy.
Ye-
She doesn't have
Yes.
it, but we find out that she has the KEL antibody positive. So maybe it's the KEL antibody thing that is causing the babies to die.
Okay.
That's what is happening here. So now the question is asking why, where do you think she got the KEL antibody? What that's the question of how does she got this KEL antibody? And those are the options are threaten abortion, whatever, all these things. But now in the explanation, they're saying that for you to get any kind of exposed to any kind of antibody or antigen or whatever, you need to have gotten a lot of blood exposed. You need to have been exposed to a lot of blood. And in threatened abortion, it's just a little bit of blood from the fetus that you get exposed. And in what else? RH immunoglobulin, previous administration, whatever. We know she doesn't have the RH immunoglobulin, so we know it's not. Even if she had it, she didn't develop it, so it's not that she doesn't have that. So the only way that she got exposed to a lot of blood is the blood transfusion that she had like 2 years ago. When was that? Whatever, 2 years ago. She had a lot of blood transfused to it. So that's probably how she developed that KEL antigen. So the question is just how did she get that antibody that is not, yeah, that is not common, whatever.
Okay.
Yeah, yeah. So
Now,
and then the thing about they're saying that she probably got it from the blood transfusion also because the US doesn't screen the blood
Kel.
that they transfuse. Yeah, they doesn't screen. They probably do screen it for the RH one, but they don't
Yes.
screen it for the KEL. Yeah, so that's probably why she got it. I think that was the point of the question.
Yes. That's the explanation. Okay, I got
Mm,
it.
okay. Next. Wait, why is it not ABO? Can you read C?
Okay, I'm reading option C.
Yeah.
Maternal ABO does not put her at increased risk of development of ice immunization, while ABO incompatibility between a mother and her fetus causes anemia in the newborn or even erythroblastosis fetalis. Her blood group would not make her most likely to develop KL isoimmunization and after being exposed to KL antigen in the transfused blood.
Okay.
The
Okay.
ABO incompet
Mm-hmm.
are sorry ABO incompatibility. Are you talking about the ABO incompatibility?
Mm-hmm.
In ABO incompatibility, there is no significant problem happens like mild
Okay.
jaundice happens, but
Okay.
RH incompatibility can cause erythroblastoma fetalis.
Is
And
jaundice you mean ABO compatible? Is jaundice in the baby or in the mom? In the baby.
in the baby,
Okay.
like mild jaundice, and then it uh, then everyone becomes okay. Then the baby becomes okay.
Okay. Next, 92 men admitted after a neighbor found him lethargic in his home. He's 92. The neighbor reports that the patient has no living relatives, so she visits him regularly. On admission, he's agitated, belligerent, and confused and said that he sees angels and demons. Temperature is normal, pulse is high, respiration high, BP super high. On pulmonary exam, crackles are heard over the long basis. Serum study shows urea nitrogen concentration. I guess is high. Let me double check. And creatinine is high. Treatment with antibiotic therapy is began for pneumonia and UTI. 4 hours later, he pulls out his nasogastric tube and IV urinary catheters. 3 days later, mental status exam shows no evidence of visual hallucinations. He recalls 0 out of 3 items after 5 minutes. The most appropriate next step in discharge planning is to contact which of the following within the hospital.
Okay, there are a lot of factors to consider when approaching the decision of safety discharge a patient. In this situation, this patient has no living relatives and is checked on by his neighbor regularly. He was found to have pneumonia and urinary tract infection, which luckily had not yet progressed to sepsis. However, these raises concern about whether this patient is able to care for himself after sufficient treatment of pneumonia and urinary tract infection. The patient is no longer showing evidence of hallucination. At this point, it is appropriate to assess the patient's mental status to evaluate his capacity and ability to take care of himself. Since he was then unable to recall any item after 5 minutes, this should raise concern that the patient has significant cognitive deficit and would not likely be safe to live at home on his own. Because of this, involving social service at this time to arrange placement in supervised living facility in the appropriate next step. The safety of this patient should always be first. Okay.
Okay. Yeah. Oh. 67. Woman comes to physician because of 1 week history of episodes of vision loss in her left eye. She has had 3 episodes during this time. Each episode lasted 5 minutes and resolved spontaneously. She has 10-year history of hypertension and 2-year history of arthritis, mitral valve prolapse. Her medication is Sinopre ibuprofen. Blood pressure is high. Photograph of the left fundus is here. On cardiac exam, there is a mid-systolic click and grade 2 out of 6 less systolic murmur, heard best at the apex. Reminder of the exam, including neurological exam, is fine. Which of the following is the most appropriate next step?
What is your diagnosis?
TIA, Amora 6 fugas.
Okay. Amarusis. Okay. Amarusis fugax describes brief episodes of transient unilateral painless vision loss is indicative of retinal ischemia embolism. Retinal ischemia as a result of microembolization. Retinal ischemia as a result of microembolization of the ophthalmic artery. It precedes, it often precedes the onset of central retinal artery occlusion, which is considered an ophthalmic stroke. It is often proceeds to the onset of central retinal artery occlusion, which is considered as ophthalmic stroke. This patient's fundus photograph is notable for this patient's fundus photograph is notable for several horse, several Holland horse plaque, several Holland horse plaque, which are yellow refractile cholesterol emboli, yellow refractile cholesterol emboli that may be found with the retinal arteries and often at the arteriolar bifurcation. A history suggestive of amaurosis fugax is clinical identification of Holland horse plaque should prompt uh, an emergent evaluation for source of potential emboli, the majority of which originate from the carotid artery. This patient's amaurosis fugax and history of hypertension suggestive of ulcerative plaque on the left carotid artery. Evaluation should include prompt carotid duplex ultrasonography treatment of carotid vascular and cardiovascular disease can prevent the central retinal artery occlusion, which may present as irreversible blindness and stroke. Okay,
What are the whole step whatever pack? Is it these things? Oh no, it's
the
just
yellow one, like
this one. Just little things.
sorry, yes,
This
this one.
these little things.
Yeah,
Okay.
yes.
Okay. 47 men comes to the clinic because of a 3-month history of worsening dull pain in my stomach and generalized itching. He has had a decreased appetite resulting in 25-pound weight loss. Eating does not affect the pain. He has had no fever, chills, vomiting, or diarrhea. His last visit to the physician was more than 30 years ago. He takes no medication. He has smoked for like 30 years. He doesn't drink alcohol or use drugs. He is BMI is fine. Vital signs normal. Abdominal exam shows fullness, a mild tenderness to palpation over the epigastric region. Rectal exam is fine. Test for occult blood test is negative. Neurologic exam shows is fine. Total bilirubin is high. Alphos, I believe, is high too, and AST and ALT are high. Which of the following is the most appropriate next step in diagnosis?
This is another question. Oh, okay. What is your diagnosis?
I don't know. I was gonna say issue with the liver, I thought, but it's red. It's not that.
Pancreatic cancer is very tough to diagnose.
Yeah, yeah. I would have gone with like liver issues, but I guess when they keep saying epigastric region, I guess that yeah, think of pancreatite of pancreas. Okay, and he lost weight, I guess, and he smokes. Okay, they gave a lot of clues though.
Okay. Pancreatic cancer is associated with high mortality rate. It commonly presents after becoming locally invasive or metastatic. It classically presents with fatigue, unexplained weight loss, and unexplained weight loss and painless jaundice. So fatigue, unexplained weight loss, painless jaundice. Physical examination may show hepatomegaly, cachexia, and right upper quadrant or epigastric mass. On palpation of the abdomen, lab studies are frequently hyperbilirubinemia as seen in this patient, indicative of cholestasis secondary to compression by pancreatic head of the carcinoma. For tumor arising in the body or tail of the pancreas, for tumor arising in the body or in the tail of the pancreas, migratory superficial thrombophlebitis as well as arterial and venous emboli can occur. Occasionally, pancreatic cancer is diagnosed as incidental finding on imaging study used in the evaluation of another pathology. Risk factor for its development include smoking, obesity, chronic pancreatitis, and family history or genetic predisposition, among others. Treatment with surgical resection, which is best a curative option because of this a mass is isolated to the pancreas and is more likely to be resectable and thus associated with improved prognosis. This patient likely has pancreatic cancer as he is presenting with painless hyperbilirubinemia, unintentional weight loss, abdominal fullness, 30-year-old smoking history, as well as mild increases in ALP, ALT, and AST. CT scan of the abdomen with contrast is the most appropriate imaging to evaluate for suspected cases of pancreatic cancer. Okay.
Okay. Next. 72 woman brought to the ED 30 minutes after her son found her confused in her apartment. She lives alone. The outside temperature is high, 105, and she does not have air conditioning. En route to, she was combative and oriented to person, but no place and time. On arrival, she's unresponsive and diaphoretic. Her temperature is 104 Fahrenheit. Pulse is normal, respiration high, blood pressure low. Mm, Pulse oximetry on 10 liters of oxygen by nasal cannula is like 98. Exam shows the corticate posturing. The skin is warm, the pupils are equal and reactive to light. No signs of injury are noted. Which of the following is the most appropriate next step in management?
So temperature 104
So that's the stroke.
stroke
That's not the.
and in heat exhaustion, what would be the difference?
It will be less than 104. That's what I remember. I remember. Okay, wait. Okay, I know the heat stroke also will have neurological issues, but I remember more the temperature. I don't know
Yes,
why.
temperature is low. In heat
Yeah,
exhaustion, temperature is low. I got it.
yeah.
But uh, is only the temperature is the differentiating point?
No, I know heat stroke will also have neurologic issues, and exhaustion won't have the neurologic
In
issues.
heat exhaustion, maybe there may be mentation, like mental status, like is normal. Mentation remains normal.
Mm-hmm.
This patient is confused. In
Mm-hmm.
where when there is stroke, patient become confused. So
Mm-hmm.
this may be the another clue to differentiate between heat stroke and heat exhaustion. Okay, I'm reading the explanation. Okay, this elderly patient, um, this elderly patient presents with signs and symptoms of Heat stroke is characterized by increased body temperature that occurs when the body is exposed to high environmental temperature and high humidity. Commonly occurs in young athletes or elderly patients with impaired thermoregulatory capacity, excessive heat exposure, and increased core temperature that leads to cardiovascular and neurologic dysfunction with secondary tachycardia, tachypnea, hypotension. Vasodilation and superficial blood vessel may lead to multiple organ failure, therefore liver and kidney ischemia, rhabdomyolysis, DIC may happen. Labs show hypernatremia, hyperchloremia, hyperkalemia, everything is hyper, increased serum creatinine, increased urea nitrogen, increased CK. Treatment includes ice, water, continuous core temperature monitoring, support of airway, breathing and circulation. Heat stroke generally requires neurologic symptoms to be diagnosed, alter mental status. progressing to obtundation in this case, whereas heat exhaustion presents similarly but with an intact neurologic examination. Okay.
Okay, next. 15 girl brought to the ED 2 hours after ingesting a handful of non-prescription diet pills. She has severe pounding headache and chest pain. Her temperature is fine, pulse is low, respiration fine, BP is super high. Exam shows generalized hyperreflexia. Which of the following is the most appropriate next step in management?
What is your diagnosis?
Mm, mm, don't know. What is she ingested? Like, I don't know.
Is there anything written like non-prescription diet pill?
Diet pills. So diet pill, diet pill.
Diet pill are like semaglutide and
Oh,
like orlistat, and another is like phentermine.
okay. Fentanyl. Okay.
So this phentermine. Okay, this patient experiencing hypertensive emergency after having overdosed being overdosed on over-the-counter diet pill. The pills she take ingested were phentermine, a sympathomimetic medication that increase the release of norepinephrine from the hypothalamus and thereby suppressing appetite and causing alpha adrenergic receptor mediated vasoconstriction. In overdose, phentermine can cause hypertensive emergency, which is defined as blood pressure greater than 180 over 120 with evidence of organ damage, cerebral perfusion, acute pulmonary edema, hypertensive encephalopathy, acute kidney failure, and retinal hemorrhage. Some some common presenting symptoms: headache, epistaxis, lightheadedness, neurologic deficits in patients with hypertensive emergency secondary to sympathomimetic medication toxicity, alpha blocker, phentolamine, or a vasodilator, sodium nitroprusside are potential treatment. IV sodium nitroprusside therapy releases nitrous oxide, acts as an arterial or venodilator, counteracting the vasoconstrictive effect of phentermine, thereby decreasing blood pressure. Okay.
Okay. Next. 22 woman comes to the physician for routine health. She has had a cardiac murmur since early childhood. She drinks alcohol occasionally, like once weekly, and smokes cigarettes only when she drinks. She's sexually active and uses OCP. She has had one lifetime sexual partner. Temperature is fine, pulse is fine, respiration fine, BP bit low. Um, S2 is widely split. 3 out of 6 meet systolic murmur. Her best at the second left intercostal space. Reminder of the exam is fine. Over the next 10 years, this patient is at greater risk for which of the following conditions?
Okay. ASD, atrial septal defect, uh, defect in the interarterial septum, the common type of ostium secundum defect, and the ostium primum defect associated with Down syndrome. Ostium primum is associated with the Down syndrome. The atrial septal defect results in left to right shunt with abnormal flow of blood from the left atrium to the right atrium, resulting in relative volume overload in the right atrium and the right ventricle. These increased stroke volume in the right ventricle. This increased stroke volume in the right ventricle result in delayed closure of the pulmonary valve, which presents as fixed which presents as fixed widely split S2 and low-grade physiology ejection murmur on cardiac auscultation. In the atrial septal defect remains uncorrected. If atrial septal defect remains uncorrected, it can result in development of the Eisenmenger syndrome secondary to prolonged pulmonary vasculature remodeling and resulting in pulmonary arterial hypertension and shunt reversal, leading to cyanosis.
Okay, next. 14 girl brought to the physician because of 1 week history of malodorous vaginal discharge. The discharge is gray and causes my itching. She has not had burning with urination. She has not had burning with urination. Urinary frequency or urgency or abdominal pain. Menarche was at 12. Her last menstrual period was 2 weeks ago and lasted 5 days. 2 weeks ago, she completed a 10-day course of antibiotic for strep pharyngitis. On questioning, she stated that she usually takes showers but occasionally takes bubble baths. When interviewed alone, she reported that she had sex once 2 weeks ago and her partner used the condom. Pelvic exam shows a small amount of gray white discharge in the vagina. The cervix appear normal. There are no rashes or excoriations on the perineum. Pubic hair development is fine. A wet mount preparation of the vaginal discharge shows few leukocytes, numerous epithelial cells with granular appearance and irregular margins and many coccobacilli. Which of the following is the most likely explanation for this patient's symptoms?
So, what is your diagnosis here? Like
Mm, I was,
coccobacilli, gram variable coccobacilli.
was going for Gardnerella, but Gardnerella is not, is it?
Yes, bacterial vaginosis, Gardnerella.
Wait, Gardnerella is not a protozoan. It's not, right? It's
Is a
Trichomonas, that's a protozoan.
yes,
Or
Trichomonas is the protozoan. Gardnerella is the bacteria.
bacteria.
Gram
Okay.
variable coccobacilli. So
Mhm,
treatment is metronidazole,
mhm,
and in here we will found the clue cell. Like on
mhm.
wet mount preparation, we'll found the clue cell. This is the thing we need to remember. And in here, vaginal pH is over 4.5. Like fishy odor, in the sketchy there is fish market where there is fishy odor, and guard and wet mount preparation show the clue cell. The policeman is not getting any clue in the according to the sketchy.
Okay.
Okay,
Okay. We are done.
okay,
We'll see you tomorrow.
okay.
Bye.